Hi, my name is Letitia AshbaughL. I am currently a charge nurse for the cardiac cath lab, and I have been for the past 8 years. I did recently graduate in December with my family nurse practitioner. I start my new position in 2 weeks for vascular surgery and patient rounding. So I'm really excited about that. I'm currently transitioning into advanced practice role as a acute care practitioner due to the requirements of my new position. It requires me to have my acute care within 5 years of hire. So I have decided to go ahead and start that pursuit now. I am drawn to acute care because I like that patients can change within hours versus in primary care where it's more weeks to months that you see these changes that take place. Um, I like that you're bridging prevention to acute intervention together between the two, just to reduce these patients being admitted to the hospital or getting home from the hospital. Primary prevention with tobacco cessation. So you honestly just ask the patient their smoking history, their pack year, if they're ready to quit, offering ways to quit. So whether they want to use and referrals to help the patient. So when it comes to smoking cessation, this is a big deal when it comes to acute admissions for CHFers or COPD exacerbations. You really want to emphasize a quit plan if the patient is ready to reduce readmissions or days that readmissions or longer admissions. Vaccinations is another way, again, with COPD, CHF, diabetes, acute kidney influenza, pneumonia, COVID-19. You want to make sure that those vaccinations are up to date, and maybe put in some discharge orders or protocols for that patient if they are in the hospital to have that done once they go home, if they hadn't had it, to help reduce readmissions or just returns to the emergency department. There are times that genetic risk actually take place, and so there are other options as far as what medications and things we get. If you're looking at like ASCVD scores to check their risk of having a heart attack or a cardiovascular event, those are good tools that we use, and that helps to early identify whether the patient needs statin therapy, and if it's an intense statin therapy that we should, and whether they should go ahead and consult cardiology. These things like the ASCVD score actually help us reduce the risk of high risk acute events like stroke or MI. And of course, routine screening. So we want to make sure that our patients are going in for their colon, rectal, breast exams, and making sure that we are sending that over to the PCPs when they do leave, that they need to have these done. While they are inpatient, some of the things we can do is counsel on red flag symptoms. So that way, if a disease process starts and they see some things that are alarming, like blood in the stool, pains or anything like that, it can be from large bowel obstructions to all the way to a malignancy. And so just teaching a patient to understand what are normal for their disease process and what isn't. Each intervention that we do decreases triggers. So smoking lowers COPD, smoking cessation lowers COPD exacerbations, same with CHF. Doing your A1C scores also is a way for screenings to make sure that we are keeping our blood glucose in a therapeutic range, to prevent late-stage presentations that require a higher level of care. Secondary prevention like cardiac rehab and pulmonary rehab, those are great things for patients to initiate referrals for. So cardiac rehab will help reduce, their just functional capacity overall and medication adherence, and sometimes reduces the 30-day readmission rates. pulmonary rehab for COPD patients. They can do things in your asthma patients for proper inhaler technique, action plans for their asthma, oxygen safety, and it just honestly reduces the hospital length. So those are some important things that we should look for. And then just pathways in general for congestive heart failure. So early diuresis, daily weight, sodium restrictions, telemonitoring programs, diabetes. So looking at their actual A1C levels and their blood pressure, glucose, monitoring flags that would admit them to ICU. And then just following up with appointments. So big things that you want to think about with these patients are also comorbidities. So there are a lot of things that we can do to assess this patient. So by their A1C, volume status, are they on anticoagulations? And then just looking at those high-risk meds. So your antiplatelets, DOACs are high risk. Just making sure you're looking at a medication list in general. There are a lot of tools that we use in the procedure world. So there's the risk assessments, there are sedation scores, there are already scores that show you, to help you guide decisions on timing and whether or not they need to go to a PACU, anesthesia care, or what's happening post-procedure. Bleeding balance, so when you're looking at VTEs and their risk, so you want to outweigh medications and bridging strategies when it comes to that. And then of course always infection and renal risk. You want to make sure there's a lot of MRSA screenings that take place in the hospital and tools to look at their kidneys, to just making sure that we're adjusting contrast exposure, medications that may be affecting their kidneys, and just overall fluid balance. The risk assessment influences things as far as the level of care the patient needs. Is advanced support needed? It also informs you whether you need to delay a procedure or not, if the patient is declining. And post-op pathways kind of cut that lining as far as what you need to do if a patient is decompensating. So as a personal growth for acute care nurse practitioner, I want to be able to make my decisions and with evidence-based practice and improving safety and outcomes of those patients. And I want to integrate both primary and secondary prevention into these acute episodes to reduce the patient from coming back inpatient for an ICU or any kind of admission within the hospital. And that we can do that in many different ways as far as vaccinations, rehabs, and just monitoring the patient and aligning with just measures as far as that goes, quality measures. And we do a lot of this stuff in the hospital by order sets, standardized order sets for COPD and congestive heart failure. Combining the discipline with prevention and risk stratification is how I plan to deliver safer care. Hopefully that will result in fewer complications and better long-term outcomes as a acute care practitioner versus my family nurse practitioner.